My next panelist is Karen Chrisman from the Bluegrass State of Kentucky. She is the staff attorney for the Kentucky's Governor's Office of Electronic Health Information, the state designated entity, Office of the Health Information Technology Coordinator for Kentucky. Ms. Chrisman has led the GOEHI staff in administering a subaward from the National Council for Community Behavioral Health Care. Karen. Next slide, please. There you go.
Good afternoon, and thank you so much for this opportunity to present the work of the Kentucky Health Information Exchange. The goal of our Health Information Exchange continues to be the support of complete interoperability of the diverse healthcare landscape of the Bluegrass State. As of this morning, KHI has 1,300 provider locations across the Commonwealth submitting and retrieving data using KHI's technology platform. What you see behind you is a representation of that technology platform. There are an additional 371 provider locations using the direct protocol, and KHI's Health Information Service Provider, KHI's HISP, to exchange secure email containing protected health information. These providers use KHI to make an average of 1.1 million community health record inquiries. The community health record is the portal used by providers to retrieve patient information. Additionally, providers make 250,000 continuity of care, or CCD, requests per month. Now, to this particular audience, that may not be of a whole lot of interest to you, except that within that provider community, there are currently 5 behavioral health locations and the Fayette County Detention Center actively sending and retrieving information. Also, within our KHI, what we call the queue, there is the Louisville Detention Center working on connectivity with us. There is also many more behavioral health centers and also our community healthcare centers within the state of Kentucky working towards connectivity. Even better than that, all of our state mental health, these are inpatient psychiatric hospitals, are in the process of adopting electronic medical records, and they will all be within this network. We have one of those hospitals actively within our queue currently. So all of those psychiatric records will be within this Health Information Exchange network. The Fayette County Detention Center provides medical care to 24,000 individuals annually. Daily, 90 inmates are seen by behavioral health physicians from the Bluegrass Area Community Mental Health Center. Per day, 195 inmates are seen by a nurse, and 865 inmates will receive medication. This information is available to the inmates' treating providers on release from the facility through KHI technology. This is real-time technology, not their Medicaid claims information, but their health care information, a full data set available through the detention center. The forces that directed this diversity of the KHI healthcare providers within our Health Information Exchange were leadership, design, and demand. The initial and continuing stakeholder group for KHI includes behavioral and public health. Kentucky Community Healthcare Centers were developing and devising a strategy for care coordination and healthcare innovation or healthcare integration as KHI was evolving. In early 2012, our community healthcare centers approached KHI about participation in the Health Information Exchange. but unfortunately, a universal consent form for HIE did not exist, just as our previous speaker talked to you about. Fortunately, KHI received funding through the SAMHSA HRSA Center for Integrated Health Solutions and the National Council for Behavioral Health Care. KHI, working with a stakeholder group from Kentucky, developed that universal consent form. It addresses the challenges that everybody in this room knows about with 42 CFR Part 2. That consent form ensures that all of our clients understand that there is no consent and KHI will never accept psychotherapy notes. A behavioral health patient for Kentucky agrees that they must share records with the HIE and that it is a complete data set. We do not have the technology to parse a CCD. So literally you are all in or you are all out. The to whom section and the language of 42 CFR compliant consent form requires a patient and an alcohol or substance abuse program must see a complete list of all of our providers in the HIE when the consent is signed, and we have a compliant process that allows them to do that. Additionally, within KHI, we have a policy that alerts our providers that there is language that will be displayed in that CCD that they must include the non-disclosure language of 42 CFR Part 2, as well as there is hard coding within the HIE that displays this language. When KHI onboarded our detention center, and the Fayette County Detention Center was the first, when we did that onboarding, there was a series of meetings that were required to carefully explain to the detention center what a 42 CFR Part 2 program was. It was a learning process on behalf of the detention center, for their attorneys, and for the Fayette County Urban County government. But that was just another process that we went through. They understood, we understood, they made a determination. The detention center is using consent, but they made a determination that they were not a 42 CFR Part program. KHI, to this day, continues to believe that if a health information exchange is to reach its true potential of being a provider of seamless care and support of a patient in the continuum of care, this must include all patients, regardless of their diagnosis or their treatment setting. Thank you.
Thank you, Karen.